In this session, we would be discussing the different rhythms that originate from above the level of the ventricles. There would be several EKGs, and when a new one shows up on the screen, for making the best use of your time, go ahead and pause the video and think about what the underlying rhythm is, and then play it. So the first EKG is that of a 19-year-old with chest pain after the person sustained a fall in a football game. When interpreting this EKG, notice that the rate is somewhere between 75 and 100. Notice that the P wave is upright in lead 2 and inverted in AVR, and this is normal. Also notice how all the different P waves are pretty similar in terms of how they look. The PR interval is approximately constant, and every P wave is followed by a QRS complex. So this would be a normal sinus rhythm. So the next case is that of a 40-year-old who presents with chest pain, cough, and fever. Notice how the rhythm is clearly irregular. For instance, the duration of this beat is significantly shorter compared to the duration of this beat. So when we're estimating a rate, a good way to estimate the rate would be to count the total number of QRS complexes on the EKG and then multiply that by 6. So the heart rate's about 13 times 6, or about 78. Notice that the P waves are upright in lead 2 and inverted in AVR. So the axis of the P wave seems to be okay. And notice how pretty much all the P waves have fairly similar morphology, and the PR intervals are relatively constant. So this would be sinus arrhythmia. Sinus arrhythmia is fairly commonly seen, particularly in younger individuals, and it occurs because when people breathe in air, the vagal tone decreases and the heart rate increases. When people exhale, the opposite happens. Now, in this case, though, the variation in heart rate is much higher than what you would expect in most people with sinus arrhythmias. Let's move on to the next EKG. So this is a 16-year-old with poor eating habits. Right off the bat, notice how the rate is less than 40, so there is underlying bradycardia. Also notice how the P waves are upright in lead 2 and inverted in AVR, so the axis is okay. Notice how the P waves in the same lead are fairly similar looking, and the PR interval is approximately constant, and every P wave is followed by a QRS complex. So this would be sinus bradycardia. In addition, notice this wave immediately after the T wave. So this would be called the U wave. And this can be seen in people with severe bradycardia, or sometimes in patients with hypokalemia. Now, given that she has poor eating habits, hypokalemia is a possibility. The next EKG is that of a 40-year-old who presents with chest pain, cough, and fever. So the rate of the EKG is approximately about 150 beats a minute. And while the P waves are pretty difficult to notice at first glance, notice that just after the T wave, there is a second peak which represents the P wave. So if you closely pay attention to it, you see these second notches which represent the P wave, and these are upright in lead 2 and they're inverted in AVR. So the axis of the P waves is normal. Notice how the P waves all look pretty similar. The PR interval seems to be fairly constant, and every P wave is followed by a QRS complex. So this would represent sinus tachycardia. Now, this EKG is that of an 80-year-old who presents with syncope. Now, right when you glance at the EKG, you can see this prolonged flat line. You can see another fairly long flat line and another prolonged flat line, and all these would be sinus pauses. Now, notice how after the sinus pauses, you have these episodes of increased heart rate. So the heart rate is now higher, and it's pretty difficult to see any P waves in this area. So this would be an example of junctional tachycardia. When you see elderly people with periods of low heart rate, sinus pauses, and then periods of high heart rate, especially if they're symptomatic, you would want to consider the diagnosis of tachybrady syndrome. So, thus far, we've talked about some of the different rhythms that originate from the SA node. So, essentially, when we're discussing sinus rhythm, you have a heart rate of 60 to 100. The P waves are upright in lead 2 and inverted in lead AVR. The P waves all look pretty similar. PR intervals are constant, and typically every P wave is followed by a QRS complex. Now, in sinus arrhythmia, everything looks similar to a sinus rhythm, with the exception that there's slight irregularity. The heart rate goes up when a person inhales and goes down when a person exhales. In sinus bradycardia, the heart rate is lower, but otherwise, again, the axis of the P wave is normal. P waves look pretty similar. Every P wave is followed by a QRS complex, and the PR interval is okay. In sinus tachycardia, the heart rate's over 100, but otherwise, again, the axis of the P wave is normal. P waves look similar. PR interval is constant, and P waves are followed by QRS complexes. And lastly, in sinus pauses, you see a flat line with no P waves because the SA node suddenly stopped working. In elderly people who are not on heart rate slowing agents, when you see a sinus pause, especially alternating with periods of bradycardia and tachycardia, consider the diagnosis of sick sinus syndrome, which may potentially need an intervention. So let's move on to the next section. You have a 45-year-old who's presenting with palpitations. So the axis of the P wave, the P waves are upright in lead 2 and inverted in AVR, so that looks okay. The heart rate's about 100. Notice how the P waves look pretty similar, and the PR intervals are fairly constant, and the P waves are typically followed by a QRS. So thus far, it looks like sinus rhythm. However, notice this specific P wave. Now, unlike the other P waves, it's happening faster than you would expect it, and also the shape of the P wave is different. So this would be an example of atrial depolarization that's occurring prematurely and not originating from the SA node as evidenced by the change in the shape of the P wave. So this would be a PAC. Now, if you see a similar wave, but it's happening after you would expect a P wave, so let's say, there is a long pause and then you see a weird looking P wave, so that would be an atrial escape beat. Let's move on to the next EKG. So this is of a 50-year-old who's presenting with palpitations. So the rate is probably about 100. Notice how the P wave is inverted in lead 2 and upright in AVR. So, in other words, the axis of the P wave is flipped. So, that tells us that the origin of the impulse is not really from the SA node, but from some focus outside. And this would be an example of an ectopic atrial rhythm. Now, this is a 55-year-old who presents with cough, phlegm, and fevers, and this person has a history of smoking. Now, looking at it, the heart rate seems to be slightly irregular. So let's go ahead and calculate the heart rate by multiplying the total number of QRS complexes with 6. So the heart rate's about 16 times 6 or 96. And then if you notice the P waves, they are upright in lead 2, and well, the shape of the P wave in AVR kind of changes. So it tells us that the axis of P wave seems to be changing. And also now if you look at the rhythm strip, so the one at the bottom, you would notice that the P waves are all of several different morphologies. And also the PR interval is changing. Every P wave is still followed by a QRS. So this would be an example of a rhythm that's originating from multiple foci. If the heart rate's over 100, so if there's tachycardia, it would be called multifocal atrial tachycardia. And if the heart rate's normal, it would be called wandering atrial pacemaker. Now, this is a 50-year-old who's presenting with palpitations. Now, in this EKG, notice that the rate of the QRS complexes is changing over time. For instance, the duration between the two QRS complexes here is different from the two QRS complexes here. Also notice that there seem to be these weird looking waves which are pretty regular. Sometimes they are hidden in the QRS complex, but after accounting for it, they are pretty regular. Notice that the duration of time between these waves is approximately equal to 300. And when you see this, it's typically characteristic of atrial flutter. Another thing with atrial flutter is that usually some of the waves are blocked off at the level of the AV node, and so not every wave goes through. So if every second wave goes through, you would call that a 2:1 block. And if that's the case, the rate of QRS complexes would be about 150. And if it's a 3:1 block, that is 1 out of 3 beats is getting conducted, the number of QRS complexes would be 100, and so on and so forth. Now, in this person, notice that the block is variable. For instance, here, the 1 beat is not getting conducted, but the next one is. But in this example, notice how this isn't conducted, this isn't conducted, but this beat is conducted. So this would be an example of atrial flutter with variable block. Now, differentiating this always from atrial tachycardia can be pretty difficult, but then a few things to keep in mind. Atrial tachycardia is usually slower. There would be times when you would see a flat line on the EKG. So, for example, in this EKG, you can see the flat line there. And also, if there are multiple P waves, because the rate's faster, there is usually a return to baseline between each P wave. Contrast that to atrial flutter, where the rate's so high that pretty much it's hard to see a return to baseline. The next EKG is that of a 70-year-old who's presenting with new left-sided weakness. Now, obviously, when you're thinking new left-sided weakness, you would want to consider a stroke. And again, right off the bat, notice that there is a pretty profound irregularity in the rhythm. So if you were to count the heart rate, it's going to be 13 times 6 or about 78. And notice how it's extremely difficult to see any P waves. Now, if you were to use a magnifying lens, you might probably see that there is irregularity of the baseline here. So what we're seeing is an irregular rate and no obvious P waves, and this is characteristic of atrial fibrillation. Now, this is a difficult EKG. This is a 70-year-old who's presenting with nausea and vomiting. So if you calculate the rate, notice how the number of QRS complexes are 10. So the ventricular rate is about 60. Now you take it a step further and count the number of what seems to be P waves between QRS complexes. And there are about 7 here. They're about 10 here. They're again about 7 here. Also notice that there is no specific pattern to how they're moving. Like the shape of the waves change and they appear fairly irregular. And the rate is well over 300. So this doesn't really fit the criteria for Flutter, given the rate, the fact that the shape of the waves keeps changing, and also the waves are fairly irregular. And this would be an example of coarse AFib. Now notice though how at times the QRS complexes are somewhat regular. You don't usually expect this with atrial fibrillation, and when you see that there is this degree of regularity, it could mean that there is an underlying junctional rhythm. So, in other words, there are two rhythms happening in this person. There is the atrial fibrillation, but given that there's some degree of regularity to the QRS complexes, it's unlikely that it's actually the AFib that's triggering the ventricles to contract. Instead, there's a second focus, likely in the AV node, that's triggering the ventricles to contract. Now, when you see a person showing both signs of increased automaticity in the heart, as evidenced by the coarse atrial fibrillation, and also a conduction block. So, in this person, for instance, the beats from the atria aren't getting conducted, and there is a junctional rhythm. You would want to think about digoxin as a potential cause, especially given the person's presenting with nausea and vomiting. Digoxin is a fairly likely cause. The next EKG is that of a 30-year-old who's presenting with palpitations. Now, at initial glance, the patient is tachycardic. The rate is somewhere between 150 and 300. And while P waves are pretty difficult to see, upon close inspection, you can see them immediately before the QRS complex in lead 2 as well as lead V1. Notice how the PR interval is pretty small, and this person could potentially have either atrial tachycardia or AV nodal reentrant tachycardia. Of further interest, notice how the voltage of the QRS complexes changes with each beat, but then it's not really a low voltage EKG. So this person does have electrical alterance as well. The next EKG is again that of a 30-year-old with palpitations. And again, if you look at the heart rate, it's somewhere between 150 and 300. Now, in this case, though, finding P waves is nearly impossible at first glance, but then if you pay close attention, notice how in V1 and V2, there is this small tiny upward blip, almost looking like an R prime. These are P waves that are embedded in the QRS complex, and this would again be an example of someone that potentially has AVNRT. Now we have another 30-year-old with palpitations, and in this case, again, the rate is probably between 100 and 150. And notice how between the QRS and T wave, there is this negative deflection that we see. So these are inverted P waves, and this person again has AVNRT. So the next EKG is that of a 20-year-old who's presenting with palpitations. Now, there isn't really an arrhythmia here yet, but there is a specific thing that we would want to pay attention to. Notice this initial slurring of the QRS complex. That's pretty obvious in multiple leads. So this would be an example of WPW syndrome. So what we're seeing is the initial slurring would be the delta wave. And also notice that the PR interval, so the PR interval is decreased. So when we see a decrease in PR interval along with the delta wave, you would want to think of an accessory conduction pathway and WPW syndrome. And this predisposes you to several arrhythmias. Another thing to remember with WPW syndrome, because the conduction in the ventricles is all messed up, Diagnosing things like a myocardial infarction or hypertrophy or axis deviation can be a nightmare, and an EKG might not be reliable. So, this is a 15-year-old with palpitations. Notice that the heart rate, right at first glance, is pretty close to 300 or just under 300 because there's just more than one large box between each QRS complex. At initial glance, it looks fairly regular, and the underlying rhythm could be either a supraventricular tachycardia with an aberrancy or a ventricular tachycardia. Now, predicting with certainty whether or not this is a ventricular tachycardia can be pretty challenging. Now, if you've known this person for a while, let's say the person had a prior EKG that looks like so. When you look closely, notice how there's an initial slurring of the QRS complex in multiple leads, and this would be the delta wave. So you have the delta wave. And also notice how the duration of the PR is lower. So this person actually has WPW syndrome. And because you see a wide complex tachycardia, it means that when the conduction is going from the atria to the ventricles, it's not following the normal conduction pathway. The person either has ventricular tachycardia or WPW syndrome with a re-entry tachycardia that's traveling from the atria to the ventricles through the aberrant pathway and then circling back through the AV node. And that would explain why the QRS complexes are abnormal. Contrast that with this patient, again a 15-year-old with palpitations, and we give you a baseline EKG that again shows WPW syndrome. So you see the delta waves and you see the short interval. However, notice how in this case the QRS complex is pretty narrow. This would tell us that the conduction from the atria to the ventricles is happening through the normal, more efficient pathway. So, in essence, the impulse is traveling from the atria to the ventricles in the AV node and then circling back through the accessory pathway. Now, one thing to notice when the heart rate's very high, you notice these ST segment changes, and these may not always reflect underlying ischemia. So, a very high heart rate by itself can induce STT segment changes. So now we have a 25-year-old with palpitations. Go ahead and pause the video and think about what the rhythm is. Now, if you've thought about it, notice how we know for a fact that the patient's QRS complexes are happening at a rate of 150 to 300 beats per minute, and it's extremely difficult to find pretty much any P waves in the whole pattern. It is, however, possible that the P waves are hidden in the QRS complex. So at the end of the day, this could be AVNRT. However, if you look at the person's baseline EKG, notice again that there is this slurring of the QRS complex at the beginning with diminished PR interval. So this person again has WPW syndrome, and in light of this, the more likely reason for the patient's tachycardia is likely AVRT. And you can also, as evidenced by the narrow QRS complexes, interpret that the patient's tachycardia is going down from the atria to the ventricles through the AV node, and the return pathways through the accessory conduction pathway. So, after hearing all this, you might be confused about how you can reliably differentiate between, say, atrial tachycardia, atrial flutter, AVNRT, AVRT, and so on and so forth. It looks like on certain EKGs, it might be impossible to differentiate between, say, AVRT and AVNRT. An EKG by itself would not help you answer these questions. Now, by comparing it to a prior EKG, you might find more information. Like, for instance, in this case, we found the person had a history of WPW, and that makes the diagnosis of AVRT more likely. And sometimes you may need an EP study. The EKG still helps because you're able to narrow down the differentials. For instance, looking at this EKG, you're able to narrow down the differentials to either AVRT or AVNRT. The next rhythm is that of a 65-year-old who's presenting with palpitations. Notice how in the rhythm you have P waves followed by QRS complexes. But then all of a sudden you have a QRS complex with no P wave, and it's also happening earlier than predicted. So again, here there's no P wave and it's happening earlier than predicted. So this would be an example of a junctional premature complex. And lastly, this is the EKG of a 65-year-old who's presenting with palpitations. The person has a elevated heart rate, so the heart rate appears to be between 100 and 150. Notice how the axis of the P wave is abnormal. The P waves are inverted in lead 2 and upright in AVR. And the P waves are all followed by QRS complexes. Now, given the proximity of the P wave to the QRS, this is likely a junctional tachycardia. If it were atrial tachycardia, you would expect the PR interval to be slightly longer. At this point, understand that EKG would not reliably and consistently help you differentiate between every condition. We've already seen that it might be a challenge to differentiate AVRT from AVNRT. It might also be a challenge to differentiate between junctional tachycardia and AVNRT. So the reality is, when you look at an EKG, being able to point out to one specific diagnosis can be challenging in some cases. However, the EKG would still help you narrow the number of differentials you have, and then using the patient's history and prior EKGs, and maybe in certain circumstances, even EP studies, you might be able to pinpoint the diagnosis. So now let's look at the rhythms that are not from the essay note that we've reviewed. When we're talking about premature atrial contractions, you would see that the morphology of the P wave in a PAC is different from the morphology of other P waves, and it's also going to happen sooner than expected. Contrast this with atrial escape beats that actually happen after there is a delay in a P wave happening. So you would see frequent P waves, and then for some reason there is a delay in a normal P wave, and then another focus beats, and so you see a weird looking P wave after you would expect it. In ectopic atrial tachycardia, you see weird looking P waves causing tachycardia, and this one originates outside of the SA node, and that's the reason for these weird looking P waves. Now, if you see different looking P waves with varying PR intervals and an irregular rhythm, you would want to consider either multifocal atrial tachycardia if the person's tachycardic, or wandering atrial pacemaker if the patient's heart rate is okay. Now, atrial flutter causes flutter waves that happen at approximate rate of about 300, and classically this is associated with a heart block, which is 2:1. So one beat out of every two is conducted. So the flutter waves happen with a frequency of 300 beats per minute, but QRS complexes happen with a frequency of about 150 beats per minute. Now, you could also have 3:1 block, 4:1 block, or a variable block, and this would change the frequency of the QRS complexes. In atrial fibrillation, you would see an irregular frequency for the QRS complexes, and there would be no discernible P waves. In AVNRT, you would see inverted P waves just before or just after the QRS complexes, or sometimes they may be hidden within the QRS complexes. In people with AVRT, look for old EKG that shows Wolff-Parkinson-White syndrome or WPW syndrome. Now, if the conduction from the atria to the ventricles is happening from the AV node, the AVRT would be narrow. And if the conduction is happening through the aberrant pathway, then because it's not as efficient, you would see a wide complex tachycardia. When you notice junctional rhythms, again, if you see P waves, they're going to be inverted and they might happen either just before or just after the QRS complex. And based on the timing of these complexes, if they're happening because there was no conducted P wave, that would be an escape rhythm. If it's happening earlier than you would expect a wave to happen, that would be a premature complex. Junctional escape rhythms typically are less than 60 beats per minute. If the heart rate is normal and there is an underlying junctional rhythm, you would call it accelerated junctional rhythm. And lastly, if the heart rate is elevated, it would be called junctional tachycardia. I would like to thank Life in the Fast Lane for allowing me to use their EKGs. And if you're interested in learning more, I'd encourage you to visit them. And as always, thank you for watching.